Good evening, everybody. Welcome to YouTube Live. This is Dr. Howard Elkin, the medical advocate, and I'm glad to be back. Sorry we had little problems in the beginning, but tonight we're going to celebrate Heart Month, and that's why I'm wearing red. So every February is American Heart Month. So it's a very important time to kind of regroup. And this is really for all of you and your family and friends because heart disease is so prevalent, and I'm all about prevention and appropriate treatment. So let's talk a little bit about why it's so important. Well, first of all, heart disease is still the number one cause of death in this country. So we have 655,000 people dying every year of heart disease. That's one out of four. And it's an equal opportunity killer. Males, females, old age, younger age. It's very, very prevalent. One person every 30 seconds dies of heart disease. What about heart attacks themselves? Well, 850,000 people have a heart attack every year. About 605,000 of those actually it's their first event. That means the first time they even knew they had a heart problem was with a heart attack. And you need to know that about 45% of these are silent. Now, when I was a fellow, we thought maybe 25% of heart attacks are silent. Now it's like reached 45%. So it's really important to listen to your body because we're going to be missing a lot of heart attacks that actually have no symptoms until we get to this point. So the enormity of the problem is obvious, and that's why we're here tonight. And if you know anything about me, I'm all about knowing your individual risk. Yeah, numbers are important, but I'm more interested in knowing your risk than about your actual numbers. So knowing your risk, we got to talk about a few of the risk factors. There's six major risk factors: blood pressure, smoking, high cholesterol, diabetes, obesity, and physical inactivity or lack of exercise. Those are the major risk factors. I mean, they've been unequivocally shown to be risk factors for heart disease. Now, there's a bunch of minor ones as well that I think are important to know about. Triglycerides, something called Lp(a), which I'll talk about in a minute. Homocysteine, inflammation. Now, inflammation is a big topic. We're going to spend some time on that in a future episode. But inflammation is the bane of our existence as it relates to all the diseases of aging. That's heart disease, cancer, autoimmune disorders, and also Alzheimer's. So it's a very important thing. Genetic markers, environmental pollution is huge. And also stress. And I think stress is one of those underemphasized risk factors. And if you read my bio or if you see my little video on my on the homepage of my website, you'll see that I had a cardiac event of my own several years ago. And I don't have any of those risk factors, at least not the usual ones or a family history, but I was under enormous amount of stress at that time. And if you want to read about all that stress, if you want to hear about it, you have to wait for my book coming out, which will be in a few weeks, hopefully. Okay, so the problem is that traditional medicine doesn't really address all these risk factors. It addresses what it can control by numbers, blood pressure, and cholesterol. A lot of these things really aren't addressed. I mean, has your doctor ever asked you what your lifestyle is like? What is your nutritional status like? Do you exercise? These are the things that are kind of left out. And in functional medicine, it plays a big part in integrative cardiologists. So I'm interested in that. Now, let's just go back for 1 second about blood pressure. It's still the number one risk factor for heart disease. And that's one thing I'm really bullish about. You might ask yourself, what is the normal blood pressure at any age? I'm going to tell you, it's 120 over 70. I don't care if you're 20, 30, 40, 60, 80, 90, or 100. It's always going to be the same, 120 over 70. Does that mean I try to get everybody to 120 over 70? Of course not. That'd be crazy. I'd have to give someone 3 or 4 medications. I'd have to see them every 3 weeks. It's true that blood pressure oftentimes will rise with age, but that doesn't mean it's a good thing. It's people do best if they have a lower blood pressure at any age. So I do my best to treat it aggressively, but it's really dependent on the age of the patient and their overall risk. Again, it always goes back to risk. Now let's talk about testing in general. But one takeaway is about symptoms. Now, if people have symptoms, you have to test them. I mean, again, test, don't guess. Someone has chest pain, palpitations when they exercise, shortness of breath on exertion. These are important symptoms to not ignore. Yeah, it could be anxiety, it could be other things, but you don't want to miss a cardiac problem. You don't want to miss a heart attack especially when you've just been told that 45% of these heart attacks are silent. So I stress these people. I do stress testing with either an echocardiogram or a nuclear stress test. So I actually have imaging. I try to get as much information as I can with each patient. A lot of time this is ignored. Oh, it's anxiety. It's a lot of the HMOs that really go this far. I think it's very important. Now, what about testing, laboratory testing? Now, in traditional cardiology and in medicine in general, they look at the standard lipid panels, which is total cholesterol, HDL, which is healthy, LDL, which is lousy, and triglycerides. That's just like the beginning. Okay. And we go into more integrative cardiology or functional medicine. These are the things I want you to know and to write down. You need to ask for two tests, the LDL particle size and the LDL particle number. Now, LDL particle size is really important. And I want you to remember just one thing, bigger is better. The bigger or larger the size of the LDL particle, we call it large fluffy or large buoyant, the better you are prognostically, because it's the small particle size or the small dense that are more likely to get oxidized, and that starts the inflammation process in the arteries themselves. So bigger is better. But how do you know that? Well, you don't know that unless you get tested for it. LDL particle number is another important test that your doctor can order. And this is important because LDL itself is oftentimes a calculated number. LDL particle number tells me the number of particles in a particular sample. So it's been shown to have more prognostic implications in dealing with, as far as cardiac events, who's more likely to have a cardiac event, depending on the LDL particle number. So again, that's an important thing. And how do you get these things tested? Well, your standard Quest lab is not going to do it, or LabCorp. So you have to do what's called specialized lipid testing. The two labs that I use are Boston Heart Lab and also Cleveland Heart Lab. And Cleveland Heart Lab is now part of Quest. So it's really easy to get that. You have to ask for it, but they do these tests and they do it quite nicely. Other tests I want you to know about, Lp(a). Okay, that's a fragment of LDL. It's sticky, it's inflammatory, it's not good. And patients that have elevated Lp(a) are definitely at high risk for coronary disease and cardiac events. How do you know if you have it? You don't, unless you get tested. And that's usually a standard testing that you get with the advanced lipid testing. Other one is CRP, or C-reactive protein. That's a marker for inflammation. It's non-specific, but it's not good. I've already told you the implications of inflammation. So it's very important in heart disease. So we want to know, every one of my patients, I don't care what their age is, I do a C-reactive protein. I want to know where they are. Now let's move on to metabolic. Hemoglobin A1c. I don't want to know that your fasting blood sugar is 102, 105. I want to know an average of your blood sugar over the previous 3 months. That's a hemoglobin A1c, and everybody should know that. Why? Because let's say you're 106 or 107, your doctor says, it's okay, nothing to worry about. But you could be a borderline diabetic. And why is that important? Because about 10 million diabetics are in this country, and about 88 million are pre-diabetics. And about 80 million of those pre-diabetics don't know it, because they don't get the A1C tested. They don't know the number. The doctor hasn't tested for it. You need to know your hemoglobin A1c. It's a marker on the red blood cell, and it gives us an indication of how well your blood sugar has been controlled for the previous 3 months. Okay, fasting insulin also is very important. I want to know your insulin level, because if insulin is high, that means you've got insulin resistance. And insulin sensitivity is good. Insulin resistance isn't good. So what happens, your body doesn't either recognize or use your own insulin level, your own insulin. So the body makes more. So the pancreas poops out eventually because it's churning out all this insulin to shunt your blood sugar to where it should go, but it's not working. These patients are insulin resistant, and they eventually become pre-diabetics and diabetics. Again, this you don't know unless you actually do the actual test. Vitamin D. Okay, vitamin D is not just a vitamin, people. It's actually more like a hormone. It's so important. And if you remember anything else, is that low vitamin D levels have been linked with poor outcomes with people hospitalized with COVID-19. So all my patients get a vitamin D level, and the span is like 30 to 100. Well, why are you going to be 30 if you could be 100? That's the log span. I try to shoot for something between 50 to 80, 60 to 80 is what I prefer to do. It's very important. And people that are African-American, dark skin, or Hispanics, again, darker skin folks tend to have very low levels, because the melanin pigment doesn't allow inactive vitamin D in their skin to get activated. So again, and if your doctor says, oh, it's not covered by insurance, it is covered by insurance. The code is E55.9. So write it down, people. E55.9. Medicare covers it, as does PPO insurance. So they're wrong when they tell you it's not covered, because it is. I order it all the time. And the other test is homocysteine, which is another risk factor for heart disease. It's a breakdown product of protein, and it also causes plaque in the arteries. So these are the important tests that I want you to know about and demand when you get your blood tested. There's 2 genetic markers that I think is really important. One is MTHFR, and I know what you think it is, but it's not. It's methyl tetrahydrofolate reductase. It's an enzyme, okay? And people that have a genetic variant, and 60% of us do, I'm one of them, tend to have high levels of homocysteine, or they can if that gene is switched on. And so there's ways you can treat that with supplements. It's not going to go down with diet or exercise. It's really something that can be treated with supplements, but it's good to know your MTHFR status. And the last thing I want you to know genetically is your ApoE level. If you have 1 or 2 alleles for ApoE, that puts you at risk of heart disease, because you tend to be hyperabsorbers and you actually absorb more cholesterol from your gut than the average person. It's also a gene for Alzheimer's. So it doesn't necessarily say you're going to have Alzheimer's, but people that have 1 allele, ApoE, are about like 2 to 3 times more likely to develop Alzheimer's. And if you have 2 alleles, then you're talking 12 times more likely to get it. So these are important tests. Now let's talk briefly about therapy, because I really want to get to your questions tonight. So we talked about small and large particle. What promotes small particle? We don't like that. One thing is fructose, fruit sugar. Okay, now I'm not just talking about fruit sugar. So I'm talking about the bad one, high fructose corn syrup. Okay, that's in everything that's boxed, bagged, canned. It's in every soda. It's ubiquitous in nature, and it's bad. The liver doesn't like it. Your body doesn't like it. And it definitely helps to promote small particle size LDL. We don't like small particle. We know bigger is better. Now, also an atherogenic lifestyle, sedentary, no exercise tends to help promote the larger particle size. And also, get this, guys, that low fat, high carb diet that we talked about 20, 30 years ago, it ain't good when it comes to small particle, to large particle. It promotes small particle size. So that was the wrong diet to prescribe if you're interested in increasing the size of the LDL particle. The other thing is saturated fat. Saturated fat has been maligned since before I was a student. We're talking 60s and 70s. And for some reason, the Heart Association is still sticking onto that dictum that saturated fat is bad for you. Saturated fat can increase your LDL cholesterol, okay? But it's never been shown that saturated fat in itself will increase death from heart disease or increase death from any cause. As a matter of fact, there's a couple of good things about saturated fat. Number one, it increases your HDL level. It can, which I think is useful. HDL is healthy. It also helps promote the larger size LDL particles. So remember, we want bigger is better. So that's a good thing. Sugar, people ask me, especially when they're new patients. I've had 2 recent patients that I helped spare them of a massive heart attack because we did emergency intervention on them. And what's my diet? What do I do now? I said, first of all, don't do anything right now. You just had a heart attack. Let's ease into it. But the thing I always tell them is low sugar, low carbs, low sugar. I'm more concerned about sugar than I'm about cholesterol and fat. I know that's not what you might hear from the average cardiologist. I just saw a patient today who had a heart attack at age 46, and he went to his doctor. He said, oh, you got to go low cholesterol, low fat. I don't know about that. I don't know that's the best diet. I do know that sugar is not good. It's extremely inflammatory. It helps promote inflammation. And it's been shown in certain studies that the more percentage of calories that come from sugar and basically and can increase your chance of death. The sugar is like not good for the heart. Salt, another thing that's been talked about forever. It's the most controversial topic of all times. Yes, it's true that too much salt can lead to fluid retention and elevated blood pressure and stroke. But is it necessarily a bad thing? Does it cause what about it's a bad cardiac outcomes as a result of high salt? It's never really been shown to be true. In fact, too little salt can be harmful. Sodium is a trace mineral. We need it, people. You can't live without it. So the jury is still out. I don't usually do highly restrictive sodium diets unless this person's got heart failure kidney failure or liver failure. Otherwise, I'm not that crazy about fluid restriction, I'm sorry, sodium restriction. Certain ethnic groups are more likely to be salt retainers like African Americans. But again, it really depends on the individual patient and knowing their risk. So that's my basic points. Now I want to hear from you and your questions because we went over a lot of information. So if I can get my glasses here, which I don't see, but okay, let's see. All right. Do you like high sensitivity CRP or CRP as a risk indicator for heart attacks? Okay, thank you. That's not for this gentleman. I use high sensitivity CRP for everything. It's usually when I like there's CRP and there's highly sensitive CRP. I always prefer the highly sensitive one. That's the one that I tend to do, and I do it on all my patients. I don't do it immediately after heart attack, or immediately after someone's had COVID, or immediately after someone's had a booster, because it can be high. It's your body's defense system. But I use it all the time to monitor my patients, and it's very useful. Okay, why don't doctors order these tests nowadays? Okay, probably the easiest explanation is lack of time. Doctors don't have the time. Your average doctor in a large HMO or corporate group is really supposed to spend no more than 6 to 7 minutes face to face with the patient. Can you imagine that? That's all the time they have. That's the time they're told that you should be spending with the patient. So it's easy to say, get these tests, take the statin, take the beta blocker, as opposed to do the education that we do in functional medicine, integrative cardiology. So I don't think doctors are disinterested. I think they just don't have the knowledge, and they don't have the time. That's really what I would say. But you're right. It should be done. Okay, new patient George is happy to be. Thank you, George. I'm so glad to have you here. Thank you. Okay, preventive medicine is ignored, just like supplements are not covered to prevent major illnesses. Thank you, Brocco. It's the same old thing. Doctors generally don't have an education in supplementation. I mean, I didn't. I had 1 hour of nutrition when I was in medical school. Can you believe that? But as an intern and resident, I was very interested in nutrition. So I on my own time, I met with dietitians, learned about tube feedings and enteral feedings. And then eventually, when I was in practice, I got really interested in sports nutrition. So it was just a basic interest of mine, but it was definitely above and beyond what I was ever taught. And again, you would think that in this day and age, doctors are trained to learn about this, but they really aren't, because now medicine is more specialized than ever. And I know that in the big centers like UCLA, even in Whittier, I mean, doctors don't talk to other doctors anymore. I used to always talk to doctors. I still communicate with doctors. I send them a consult note on a patient I see. I call them if it's something important, because we don't talk to each other anymore. And we certainly don't see each other anymore because of COVID. So it's like everybody's in a funnel, in a tunnel, and we don't communicate with each other. But getting back to the supplements, we don't have that background. And I think it's great because I use nutrition and supplement whenever I can, and drugs reserved when I really need it. Okay, what is a good insulin level? Under 5? Yeah, 5 is ideal, but 5 isn't really practical for most people. So I would say 8. I'll even take 10. But I want my insulin levels to be low. And by the way, they should be fasting. And again, because we're really looking for insulin sensitivity versus insulin resistance. And we've talked about metabolic health. I think it was the last one we did. We talked about that. So I really monitor insulin levels. There are a couple other tests that I also do for insulin resistance. I did mention them purposely tonight because I want you to really hone in on the ones that you need to know about to demand from your doctor. Okay, drug companies can't patent supplements. They can't. First of all, there's no money in supplements. I guess they could, but who's going to do a large, double-blinded, placebo-controlled trial with supplements? Again, there's no money in it when there's so much money in drugs. I'm just being terribly honest with you. So that's why there's, and if they do any studies at all, have you noticed this? If they do any studies at all, that the results are always like, okay, it really didn't help much, or it really wasn't marginally better, or worse. There's harm in doing so. They've done that with vitamin E. They've done that with calcium. They've done that with vitamin D. For whatever reason, when they do peer review supplement studies, they're never quite make it. And, you know, and to me, that's very damaging because the patients will come back and say, well, I guess it's not good. So I'll just wait till I get sick and then the doctor will give me drugs. That's the thinking. And that's what I'm totally against that. Okay. What oils do you suggest for cooking that are heart healthy? I just talked about that the other day. Okay. I love olive oil. There's this feeling that, okay, you can't really cook with it. I don't know if that's true. I would not use high temperatures, but I think if you're sauteing, it's fine over vegetables and so forth. The taste is good. Of course, you want to make sure it's extra virgin, cold pressed. Um, Also, avocado oil is very good. Um, I never use canola oil. I think it's if you don't take my word for it, just go ahead and listen to a 5-minute video on how it's produced. It's very industrial. Um, Coconut oil is pretty good too. I just don't like the taste on vegetables, so I don't use coconut oil myself. But avocado oil and olive oil are very good, in my estimation, as long as you don't go too high on the heat. Okay, I've heard that instead of reducing salt, we need to increase potassium as they work together. It's a good point. In fact, I wish I had more time to talk about therapeutics. We'll do that another time. But potassium is really one good way to lower your sodium level, your blood pressure. Okay, so sodium and potassium are both trace minerals, and they're essential for life. Okay, but treating with potassium will actually help lower blood pressure. And I make sure all my patients, not necessarily on potassium supplements, but I ask them about, are they eating adequate fruits and vegetables? That's your big source of potassium, and also magnesium. Magnesium is also very useful. So magnesium and potassium I use to help lower blood pressure naturally if I can. It's always, important part of my therapy. So they do work very hard. Here's a good one. I had a minor heart attack, got me out of nowhere. Does that mean that I am genetically programmed for another? Not necessarily, not at all. Again, genetics is one thing, but I fervently believe, and most people that believe in epigenetics, which is, genetics is like the gun. Okay, that's your that's your material that says what you have within your DNA. Okay, but epigenetics is the trigger. Okay, which is lifestyle. So 30% of what happens to you is, based on genetics, but 70%, most of us think it's really related to lifestyle, what you do with your genetics. So I don't think having a heart attack, could happen to me. I had a mild heart attack, and it's been, 12, 13, it's been 13 years. And I didn't even have any of the risk factors. It's just, but I had a lot of stress. And so I think it's really a lifestyle thing. And I think we spend more time on lifestyle and as opposed to obsessed about having another heart attack. And if you work with me, I work on the positive. So if I tell people when I did this to a gentleman I met today, my prayer and my plan for you is that you never have to go back to the cath lab ever for another angioplasty or stent or whatever. Now, I'm not always able to promise that, but that's the goal. That is the goal. So whether you've had a heart attack or not does not mean the end of your life. Okay, does cortisol increase the risk? Yes, absolutely, because cortisol is your stress hormone, and as you may not, it's actually not horrible. You need to have cortisol, or we could never undergo stress. So, but when it's so high, which is what's happening now. Look what the last 2 years we've been through. I see so many people that are stressed. And more, it's with every age group, from little children all the way through seniors. It's really kind of tough. Yes, there's not a lot of studies on cortisol and heart disease. Very interesting. I'm glad you asked that question. It's from the Shrink Shop. I know that it's a big risk factor, and I think there's just not enough emphasis on it. But thank you for asking that. Okay, how much does stress cause your heart attack? Look at me. I think again, when you get my book and you read it, you'll see I have a whole chapter devoted to how I got to where I am. The name of that chapter is, because when you have a heart attack at a young age, you ask yourself, why me? So the name of this particular chapter is Why Not Me? Which is what when you read that chapter, you say, gosh, no wonder he had a freaking heart attack. Look what he went through. See, I took on too much more than I could take. It's like, okay, I can take it all. Give me all the stress in the world. I'll just wear it on my shoulders. But I didn't know how to say no. And I was really stressed out and didn't know, frankly, I didn't know how to deal with it. I didn't package it well. So now I do a lot of things to help assuage that kind of stress in my life. It's work. It's ongoing work, but I think I do a pretty good job of it because I certainly am not devoid of stress. But I think I handle a lot better now. So very important. Yes. Okay. Does A1c indicate insulin resistance? Best remedy for exercise yeah, good question. A1c, yes, it can, but it doesn't have to. You can have diabetics, pre-diabetics that have A1c that's quite elevated, yet they are not insulin resistant. Why? Because their insulin is nowhere to be found anymore. See, another test that I do is called the C-peptide, which I wasn't going to mention, but that tells me how your pancreas is running. If I see a high, and I tell patients, no, your pancreas is working overtime. And if you don't do something about it, it's going to poop out. Then you're going to end up on insulin the rest of your life. So I see patients that are getting close to needing insulin because they've worn out their insulin. The pancreas can pump out, but so much before it just says, I had it, I can't. So yes, you can have an elevated A1c, 12, 13, or 14, and not have evidence of insulin resistance because you've just worn out your resources. That's not a good sign. Okay, good question. Okay, happy Valentine's Day. Thank you. Okay, exact date when your book is coming out. I'm working with the team now, and I should know. I will definitely announce it as soon as I get this done. We were hoping for the first quarter, so I got one more month left. So my goal was to have it done the first quarter of this year. So, but I should know I know whether next time I do one of these where we are with that. But thank you. Okay, let's see. Once on insulin, can you come off of it? Absolutely. It's first of all, these days there's a lot of really good medications out there. I hate insulin. I don't really use it in my practice. I haven't kept up with it. So I do best with metabolic syndrome, pre-diabetics, and diabetics that are interested in lifestyle, because I can generally use lifestyle and diet and exercise and other medications to help lower their risk and their need for insulin. But it depends on your diet, what you can do with it, and your practitioner. I think their goal should be to try to get you off of insulin, because insulin is a fat storage hormone, number one, okay? And number two, it's not easy on the heart. Insulin itself is not easy on the heart. So I usually turn these patients over to endocrinologists because I think they're better at it than I am, but I don't know how apt they are at getting a patient off of insulin and onto other medication and lifestyle. I don't think they do what we do in functional medicine, which is a shame. But is it possible? Absolutely. I think it's just like, I don't think any medicine should be for life in most cases. In most cases. Okay. Do you recommend HIT? HIT is great. Yeah, I do use it. I do it once a week with the trainer I work with. I kill myself. We go from the infrared sauna to Jacob's ladder to a power plate, and then to a new prototype for a power plate bike. Imagine a bike that actually shakes. It's amazing. And I do rounds of that in between with the infrared sauna. And by the time what I've done in 20 minutes would be like an hour on other apparatus. I think it's great. And it's for insulin resistance, it's great. HIT is a great way. You can't do it every day. Or you'll burn out. But I do think it's very beneficial. Good question. Okay. Okay. Gosh, I think these are really good questions. And I think we've gone over. Thank you, guys. Sorry for the very beginning. I guess for some reason my chat box wasn't working. So I think that's about it. Make sure I got everything here. I think we did. Good. Thank you so much. Okay, so happy Heart Month to all of you. And I won't be here in 2 weeks because I'll be involved with I'm doing a podcast with Dr. Ben Weitz and the Functional Medicine Group of Santa Monica, which will be, I will have that eventually on my website and probably also on YouTube. That'll be a more in-depth discussion So with more questions and answers. So what you didn't hear tonight, you'll probably hear then. So it'll be 2 weeks. So it'll probably be 4 weeks before I get back to you. So happy Heart Month to all of you. Thank you for attending, and I'm very grateful for that. Please subscribe if you haven't, because you'll get alerts. You should get alerts. It also helps my ratings. And if you see any of my videos, click the like button. That really also helps. Thank you so much. And we'll see you in a few weeks. Good night, everybody. Thank you.